Welcome to another episode of Clot Conversations from Thrombosis Canada. I'm David Airdrie, Executive Director.
I'm Jamil Abdulrahman, hematologist from Toronto General Hospital.
We're here to provide you with updates on diagnosis and management of thrombosis, featuring interviews with authors of recent research publications and highlights of education programs from Thrombosis Canada. Thank you for joining us in this episode.
In this episode, we'll be discussing a recent paper published in the Journal of Thrombosis and Haemostasis entitled Thrombotic and Bleeding Outcomes Following the Perioperative Interruption of Anticoagulation among Patients with Non-Valvular Atrial Fibrillation and Active Cancer, with co-authors Dr. Joseph Shah and Dr. Tzu-Fei Wang. Dr. Joseph Shah is a hematologist and thrombosis medicine specialist in the Department of Medicine at the Ottawa Hospital. He's an associate scientist at the Ottawa Hospital Research Institute and an assistant professor in the Faculty of Medicine at the University of Ottawa. Dr. Shah's research is focused on evaluating anticoagulation reversal strategies, as well as the perioperative management of anticoagulants. And Dr. Tzu-Fei Wang is a hematologist and associate professor in the Division of Hematology, Department of Medicine at the University of Ottawa, and the Ottawa Hospital, and an associate scientist at the Ottawa Hospital Research Institute. Her main areas of clinical and research interest include clinical research for optimal prevention and treatment strategies for patients with cancer-associated thrombosis, drug-drug interactions with anticoagulants, and obesity-related thromboembolism. Thank you for participating in our podcast today.
Yeah, it's great to have you both. And I'll start by asking, how are patients with cancer and atrial fibrillation different from patients with atrial fibrillation without cancer?
Thank you both for having us here today to talk about our study. So that's a really good question, and it's an area of ongoing research that really falls into cardiac oncology. And when we set out to undertake this study a few years ago, we didn't really know nearly as much on this topic as we know now. But there's this huge body of research that's coming out in cardiac oncology focusing on how there's an interplay between cancer and atrial fibrillation. So that's both in terms of prevalence. So both atrial fibrillation and cancer age is a really big risk factor. So with an aging population, we're seeing more of both of these conditions. And there seems to be an association between the two. We don't really necessarily understand why. But what we do tend to see is that, for example, patients who have newly diagnosed atrial fibrillation, they seem to be at higher risk of developing cancer in the first few months after atrial fibrillation is found. So there's this thought that there could be an inflammatory effect or an oxidative effect from cancer that might increase the risk of developing atrial fibrillation. So that's really in terms of that association, but there's also a lot of research focusing on whether or not patients who have atrial fibrillation and also have cancer, whether they're at increased risk of thromboembolic complications. So stroke would be the main thing. For example, some groups have looked at whether cancer should be incorporated into current risk prediction models like the CHADS-2 score. So there's not any definitive consensus on that yet, but there's a lot of interest in how these patients might be different compared to patients without cancer.
And I'll probably just add on to Dr. Shah's excellent comment. And again, thank you, David and Jamil, for having us here. Also, other than the association between cancer and atrial fibrillation, it's always based on our experience with cancer-associated thrombosis that we do know that patients with cancer have increased risk of recurrent thrombosis as well as bleeding, while on anticoagulation. Since atrial fibrillation is really treated, the mainstay of treatment is anticoagulation, so treated quite similarly. So there's obviously a huge interest to see if similar finding in cancer patient compared to non-cancer patient would be found, like increased risk of stroke in cancer patient, increased risk of bleeding complication in cancer patient. And there are actually some large epidemiology study did show that that's probably the truth, but certainly more studies are welcome.
Thank you. So before this study, what data was out there regarding periprocedural anticoagulation in patients with atrial fibrillation and cancer?
So there wasn't really a whole lot out there specifically looking at this patient population. As a lot of the listeners will know, there's a lot of data out there on perioperative management of anticoagulation in general. but not specifically relating to patients with cancer, and really virtually no data at all looking at patients with cancer and atrial fibrillation. So if you think of the big periop studies that have been done over the past few years, so I'm thinking of Bridge and Pause, they did include some patients who had cancer, but obviously it wasn't necessarily a focus of those studies. So if you look at Bridge, for example, around I think it's around 5 or 7% of that study did include patients with solid malignancies, but they weren't necessarily clearly defined, and the outcomes from that subgroup weren't reported. And similarly with Pause, around 9 to 10% of those patients did have active cancer, but again, the data wasn't specifically reported. We were able to get a bit of that data from Dr. Duquetis, which we'll talk about later. But really, those were the two biggest studies and didn't specifically report outcomes in this subgroup. There was a prior study that was done through the Mayo Clinic Thrombophilia Center, where they have an ongoing prospective registry looking at perioperative management of anticoagulation. And back in 2012, they tried to look at the effect of cancer on postoperative outcomes in these patients who had their warfarin managed. And really interesting results where they were able to see that patients who had underlying VTE, they did seem to be at increased risk of both recurrent VTE and bleeding after surgery. Whereas a smaller group of patients with cancer and atrial fibrillation, the cancer didn't really seem to have an effect on the risk of postoperative outcomes. And we'll chat a bit more later on how that relates to the findings from our study as well.
Yeah, so you guys did a retrospective cohort study. Can you tell us about who you included in the study and what outcomes you were looking at?
Yep, absolutely. So at the Ottawa Hospital, we see a lot of patients for perioperative management of their anticoagulation therapy. So essentially what this study was doing is it's a retrospective cohort study. We're able to fairly easily identify these patients, these patient visits. We looked back between 2015 and 2019 to try and identify all perioperative visits and then look at who among those patients had active cancer. We defined active cancer using a fairly commonly applied definition in VTE studies, but just because it's widely applied, we decided to use that same definition for these patients. So these are people with recently diagnosed cancer, recent cancer treatments, whether that be surgery, chemotherapy, or hematological cancers that are not in remission. So we essentially looked back at these patients, and we were mainly focused on postoperative outcomes at 30 days, similar to recent larger periop studies, looking at arterial thromboembolic events and venous thromboembolic events. The two main outcomes, though, were arterial thromboembolic events and major bleeding. So those were the two main outcomes that we looked at. We also tried to get a better sense of, so this was a retrospective study. It's important to keep that in mind. We didn't really dictate how physicians at the Ottawa Hospital managed anticoagulation for these patients. So we did want to also look back and see, how were these patients managed? When was anticoagulation stopped and restarted?
So you mentioned that the periprocedural anticoagulation was at the discretion of the treating physician. Could you give us an idea in general how VKAs and DOACs are managed periprocedurally at your center?
Yep, absolutely. So I'd say that in Ottawa, again, we see a lot of these patients for perioperative management. And, I did my training here as a fellow, and I had the luxury of working with a lot of the different staff physicians here in Ottawa. I'd say that everyone is really good at following current periprocedural guidelines. And there's always going to be subtleties in how physicians manage particular patients, but I'd say that we're pretty consistent with current ISTH and Thrombosis Canada guidelines in terms of when to stop and when to restart. So if we're talking about warfarin, usually we'll give the last dose on preoperative day -6, so skipping 5 days worth of warfarin. Usually, so for the most part, we try and give a loading dose when we're restarting, so double the patient's maintenance dose for 2 days. We'll often check an INR if it's logistically feasible the day before surgery in the thrombosis clinic, and give a very small dose of vitamin K if their INR is above a certain threshold, so usually 1.5. In terms of bridging, similar to what most people are doing, I'd say these days, less and less, really. So we really limit bridging to patients who we feel that are at very high risk of thromboembolic complications. People with mechanical valves, although even then we're being less aggressive with that. Patients with prior perioperative thromboembolic events, patients with recent stroke, for example, and atrial fibrillation. So we are moving away from it, but do keep in mind that this was 2015 to 2019, so we were still early on in that phase of using bridging less. And then in terms of DOAC, periprocedural management, again, very consistent with what was done in the PAUSE study, and consistent with Thrombosis Canada recommendations. Usually we stop DOACs for 1 day prior to low to moderate bleed risk procedures, and then we skip 2 days for high bleed risk procedures. And it's pretty cool because when you look at the results of the study, you can really see the separation of the standard bleed risk and high bleed risk, and see how these guidelines end up impacting periprocedural management.
Okay, great. So yeah, let's talk about the findings. What did you guys find?
So we ended up finding, I think, a decent number of patients over the course of these few years. There were 264 patients and 302 periprocedural interruptions that were identified. Fairly interesting. I mean, in terms of the demographics, these patients are pretty similar to what you see in bridge and pause as far as atrial fibrillation patients are concerned. I believe the mean age was a little higher in our patient cohort, but otherwise the CHADS-2 score was fairly similar. These patients in our study were fairly evenly split in terms of who was on warfarin and who was on a DOAC. I already mentioned that the periprocedural management, I don't think there were any surprises there in terms of how these patients were managed. Generally, the results were consistent with guidelines. Again, we have a really nice figure in our publication for the listeners who might have it open, where you can really see the separation of how these patients were managed between standard and high bleed risk procedures. I think what's really interesting when you look at this data in cancer patients and contrasting it with these other studies that I'm mentioning is that these patients do tend to undergo high bleed risk procedures more frequently than patients without cancer. If you look at this study and a prior study that we did on cancer-associated VTE, about 2/3 of these procedures are high bleed risk, whereas in larger studies like PAUSE and BRIDGE, it's really more like 1/3 of patients undergo high bleed risk procedures. So it's almost like the proportions are inverted when you look at cancer patients. And I think that's a really important piece of information from these studies. These patients do seem to undergo these higher bleed risk procedures, whether it be biopsies of vascular organs like kidneys, so kidney biopsies, prostate biopsies, liver biopsies, but also undergoing major cancer surgery. So things like laparotomy, resections of large cancers, hepatectomies, nephrectomies, things like that. So I think that's an important piece of information when you're managing these patients, is that they do tend to undergo a more significant surgery on average than patients without cancer. As far as outcomes were concerned, I also don't think there were any surprises. We undertook this study really expecting the outcome rates to be similar to patients without cancer, but we wanted to make sure that there wasn't really any differences. So there were 2 patients who experienced an arterial thromboembolic event, so they both had strokes, and the 30-day risk of ATE was 0.7%. And really, that's pretty much in line with what you see with all these studies. Thromboembolic events tend to be quite rare when you're following people for a short period of time post-op. But it's reassuring in the sense that, as Dr. Wang mentioned, these patients, there might be some kind of a hypercoagulable effect in these patients, but we're really not seeing that in terms of the limited number of events that happen post-op. And then in terms of bleeding, again, the results were reassuring. So we had 5 major bleeding events, which led to a 1.7% risk of major bleeding at 30 days. And again, those results are pretty much in line with what was seen in BRIDGE and PAUSE, considering non-bridged patients in the BRIDGE trial. And that's interesting to see, because in other studies, so our prior study on cancer-associated VTE, we did see what seemed to be a higher risk of bleeding. And we were also able to get a bit of data on the pause study, looking at patients with cancer, that also seemed to suggest that maybe there was an increased risk of bleeding. So overall, the results seem reassuring. These patients with cancer, it doesn't really seem to be impacting the risk of experiencing ATE or bleeding post-op.
If I might just add a little bit from the already excellent summary, that I think as a clinician, is really the study is quite reassuring that, we do this all the time, that we think we are doing the right thing, but it's really a good confirmation to really look at the the overall population that we have managed in over the past few years, to see that actually, the risk of stroke, it's along the line with published literature, is now totally out of bound. And also the risk bleeding, as Dr. Shah was mentioning, we have 5 major bleeding that's total of 1.7% in 30 days. But what was striking to me also, 4 out of those 5 are patient who are undergoing what's considered high-risk bleeding procedure. Like Dr. Shah was mentioning, these cancer patients, 2/3 of them, what we found is 2/3 of them undergoing high-risk bleeding procedure, it's just much more compared to the cancer, the non-cancer population. So I think that's actually an interesting piece of information to keep in mind.
And you guys also did a prior study looking at perioperative anticoagulation in patients with VTE and cancer. Can you tell us a bit about the findings of that study? And if you think, should we be managing patients with AFib and cancer different from VTE and cancer, or should we be managing the same for perioperative anticoag?
So in terms of our prior study on cancer-associated VTE, I've mentioned it a few times in the podcast already, but the idea with that study was, really the same idea, looking at periop management for patients with cancer-associated VTE. And interestingly, we did find that the outcome, the risk of outcomes at 30 days, so risk of post-op VTE and risk of major bleeding, they did seem to be slightly higher than what we expected. Now, these are fairly small studies, wide confidence intervals, so it's important to keep that in mind, that there's always that limitation with comparing risk across studies, but it seemed to be a higher risk in VTE patients as compared to the current study looking at patients with AFib and cancer. We had found a 30-day risk of VTE of 4.1% and a 30-day risk of major bleeding of 4.1% as well. What's interesting overall is when you look at the risk of major bleeding in these patients with cancer, and consider all of these studies that we're mentioning, it does seem that there's maybe a bit of a trend where these patients are at higher risk of bleeding. I'd say that's probably the main takeaway when you look at the body of the literature. And maybe that effect seems to be more significant in patients with cancer-associated VTE. Why that is, it's hard to say. It could be that these hypercoagulable mechanisms that Dr. Wang mentioned, there's a lot more data looking at those in patients with VTE. We've known about this hypercoagulability for over a century now, right? In patients with VTE, whereas with AFib patients, it's really more of a recent scientific interest. So it could be that all of these cancer-associated mechanisms are more relevant to patients who have already had VTE, particularly in patients who have just had surgery as well, so in the post-op setting. It could be that these patients who have cancer-associated VTE, maybe they're a bit more advanced in terms of their cancer as well. So a bigger proportion of patients in our prior study had metastatic cancer compared to the current study with AFib. So it could be related to that, could be related to, differences in how big these surgeries were, especially if they had more advanced cancer. But it's interesting because when we did look at the pause study, we were able to get a bit of data from Dr. Duquetis, as I mentioned previously, about the patients who had active cancer. And when you look at the 30-day risk of major bleeding in those patients, it was 3.7%. So it also seems to be a bit higher than what you would expect in an overall population. I'd say probably mainly related to the procedures that these patients are undergoing. In terms of whether or not they should be managed differently, I don't think I'd go that far. I think that they can be managed similarly, but I think one of the key messages is really paying attention to the bleed risk and maybe tailoring your plan a little bit based on that.
So what are the key takeaway points from the study? And how should perioperative anticoagulation in patients with atrial fibrillation and cancer be managed? And can the perioperative anticoagulation algorithm from the clinical tools section of the Thrombosis Canada website be applied to this?
Yeah, so I'd say that the main takeaway message is that in patients who have atrial fibrillation and concurrent active cancer, the data from this study seems to be reassuring, and they don't seem to be at increased risk of both arterial thromboembolic events and major bleeding. And that data is consistent with that prior study that I mentioned from the Mayo Clinic. But I think the main takeaway is when you look at not only this study, but our prior study and the data from PAUSE, patients with active cancer probably are going to be undergoing higher bleed risk procedures. Really important to keep that in mind. Whether or not you deviate from guidelines, I'd say again, that current guidelines apply to both of these patient populations that we've been discussing, so both cancer-associated VT and AFib. But if you're looking at the patient's perioperative management, really important to look at what procedure is being done, appropriate bleed risk stratification, and really within guideline recommended management, try and consider, for example, if you're thinking about resuming a DOAC, usually for high bleed risk procedures, the recommendation is 48, 72 hours. So maybe you want to err more on the side of 72 hours instead of 48 if you have the luxury of, if you don't feel that the patient is necessarily at very high thromboembolic risk. I'd say that the flip side is that sometimes in these patients, if you're trying to apply the guidelines to these patients and for whatever reason you feel uneasy with that, so for example, a patient who had prior recurrent thromboembolic events around the time of surgery, it's important to keep in mind that your clinical gestalt and overall clinical impression is important to maybe adjust what you're doing. And guidelines can't necessarily be applied to all of these patients in the same way. So I think the take home is really, on average, the guidance document on the Thrombosis Canada website is really, really good and applies to most patients. But to keep the bleeding risk in mind in these patients, and most of the time that's what's going to be dictating your perioperative management.
That's great. Thanks. Is there anything that we haven't discussed today that you'd like to add?
So I might add something. We recently I was fortunate to be participating in the ISTH project, and we published a guidance document on really perioperative management of antithrombotic agents for cancer patient we're mainly focusing on more minor cancer-related procedures. This was also published at JTH September of last year. But really, in the process of doing that guidance, what I really specifically kind of realize and kind of relates to studies like Dr. Shah has conducted is we truly are very limited in literature so far still. You would think that, and it's a surprise to me, to be honest, cancer patients undergo surgery all the time. A lot of them are antithrombotic agent. I would think that there's already a lot of data out there, and there's really not. All the data when you look at are more in the, even the limited data we have related to anticoagulation, more in the warfarin era. So we have very, very limited data, like Dr. Shah was conducting, especially related to DOAC, and also even a lot of cancer patients are also on antiplatelet agent. Really, the most data we have is related to aspirin, which most people consider to be quite safe even to continue, but a lot of other more stronger antiplatelet agent, we also have very limited data. So I think this is also a call to the community that we would really like to see and encourage more studies, more data like this to investigate, evaluate perioperative management in the cancer population, because I think it's important that these patients, as we alluded to throughout the podcast, that they probably have more increased risk of bleeding, maybe increased risk of thrombosis as well. And I definitely think more data can really help clinicians to fine tune the plan and improve outcomes in this population.
That's great. Thank you both for participating today. It's great to have you on board, and look forward to your future studies and working together on other projects. So Thank you to our audience for listening to Clot Conversations from Thrombosis Canada. We welcome your comments, questions, and suggestions on the podcast. And if you have any recommendations for future podcasts, please send them to us at info@thrombosiscanada.ca. And please subscribe to this podcast so that you are notified about the release of new episodes. Don't forget to check out our website for education programs, clinical tools, and guides. And also, please consider donating to Thrombosis Canada to support our ongoing efforts to reduce morbidity and mortality due to thrombosis. Thank you very much.
Thank you.